Hello and welcome to you all. So today's topic discussion is on mitral stenosis. So the mitral valve is present between the left atrium and left ventricle. Basically, our heart is divided into the four chambers: right atrium, right ventricle, left atrium, and left ventricle. So there is this mitral valve over here in between the left atrium and the left ventricle. So whenever we talk about stenosis, the word stenosis defines a small, okay? It's like a constrictive type, okay? So the normal size of the valve is 4 to 6 centimeters square, okay? So this is the normal valve orifice, okay? Decrease in the mitral valve orifice area leading to chronic and fixed mechanical obstruction to left ventricular filling. So what does this mean? This means, so whenever there is a decrease in the mitral valve area, okay, so what happens is it leads to chronic and fixed mechanical obstruction to left ventricular failure. So left ventricle will not be getting enough amount of blood, okay. So the diastolic volume of the left ventricle gets decreased because there is a stenosis of the mitral valve. More amount of blood cannot come from the left atrium to the left ventricle, okay. So the causes of mitral valve stenosis is rheumatic heart disease. It is rheumatic heart disease, congenital mitral stenosis, and a massive annular calcification with extension into the leaflets. Okay, you shouldn't. Okay, you shouldn't. You know, forget infective endocarditis. Okay, with large vegetation. Rheumatic arthritis, of course, SLE, left atrial myxoma, carcinoid syndrome. The most important being rheumatic heart disease. Number one, rheumatic heart disease. Number two, infective endocarditis. Number three is old age. Number four is calcification. Okay. So, and number five is, of course, rheumatic arthritis. Number six is SLE. So, if there is SLE, okay, SLE associated infective endocarditis, it is known as Liebman-Sachs endocarditis. Okay, it's known as Liebman-Sachs endocarditis. It's associated with SLE, associated with infective endocarditis. Okay. Now, rheumatic mitral stenosis, the most common, it's most commonly seen with females. Okay, so I still remember a case in the emergency where a female having there was mitral stenosis in a female, and we had auscultated for a moment. I was looking forward to look into the opening snap. Okay, so what is this opening snap? We'll be talking in the auscultation session. So the age of presentation is 30s, 20 to 30. So this 20 to 30s is usually secondary to rheumatic heart disease. Okay, so if it is 40s to 50s, so this is secondary to calcification. Due to senile old age, there is calcification, right? Now, isolated MS in 40% cases of RHD and a history of rheumatic fever. Okay, remaining 60% cases associated with other valvular diseases like MR and AR. Okay, you have to remember this. So, remaining 60% cases associated with other valvular diseases like MR and AR. Okay, now you have to remember this classification which has been given. Mitral valve area. So we all know that the mitral valve area is 4 to 6 centimeters square, right? Now if I decrease this area, so 1.5 to 2 centimeters square, so that's a moderate variant, okay? 1.5 to 2 centimeters square, it's a moderate variant. So whenever we talk about severe variant, we need to understand that 0.1.0 to 1.5 centimeters square, okay? And very severe means less than 1 centimeter square. So it's divided into moderate, severe, and very severe, okay? Moderate, severe, and very severe. Okay, now how can you remember this? Remember, whenever we talk about eclampsia, okay, when I was talking about eclampsia, we talked that eclampsia is divided into severe and very severe. Okay, so eclampsia is a condition, it's divided into severe, very severe. So 160 bar 90, 160 bar 110, more than 110, that's okay, severe, very severe, and 110 by 90. So just okay, let's not correlate with this one. I think this is making it more confusing. Just remember moderate, severe, and very severe. Moderate means 1.5 to 2 centimeter square. Severe means 1.0 to 1.5 centimeter square, and very severe is less than. So mean valvular gradient. So this mean valvular gradient, the pressure gradient, which has been given. Okay, so more the stenosis, more the pressure, isn't it? So to assess the severity of obstruction and hemodynamics, to assess the severity of obstruction and hemodynamically, both the transvalvular pressure gradient and the flow rate must be measured. Okay. So diagnosis. For the diagnosis, Symptoms: latent period between the initial attack of rheumatic heartitis and the development of symptoms due to MS is generally about 2 decades. That means, so someone's having rheumatic heart disease and that converts into mitral stenosis. So this duration is 2 decades. This duration is 2 decades. See, every word in the slides is important. Okay, every word in the slide is important. Okay, so valve area, I already told you. Just remember, less than 1 is very severe, 1 to 1.5 is severe, and 1 to 1.5 is severe. Okay, less than 1 is very severe, and more than 1.5 is moderate to 2. So valve area less than 2.5 centimeters square. So remember that whenever valve, the normal size is 4 to 6 centimeters square, right? So if your valve is 3 centimeters square, the person becomes asymptomatic. There is no such symptoms, right? So if the valvular area is decreased, maybe it might be less than 2.5 centimeters square, they present with an exertional dyspnea, right? A valve area of 1.5 centimeters square, is usually required to produce symptoms at rest. Okay, so if the valvular area is less than 1.5, so there will be symptoms at rest. Okay, so the person will be feeling some symptom during the rest time. Okay, an orifice of less than 1 centimeter square is considered to represent critical MS and is associated with significant pressure gradient that is necessary to maintain adequate filling of the left ventricle. Okay, so just understand, less than 2.5 centimeter, there's an exertional dyspnea, and less than 1.5 centimeter, there is symptoms at rest. So what symptoms? Of course, we are talking about dyspnea. Okay, and since it's a cardiac symptoms, we know that. So this is a mitral valve, more blood in the left atrium, backflow to the lungs. In the lungs, if the blood is too much blood in the lungs, it leads to pulmonary edema. Now from this pulmonary edema, it increases the pulmonary pressure. The left ventricle must contract forcefully to withstand this increase in the pulmonary pressure. That leads to increase in the left ventricular systolic pressure, right? So according to the Frank-Starling's law, and that leads to a biventricular failure. So patient with left ventricular failure now can present with a right ventricular failure. Okay, and that leads to a problem. Okay, now next is dyspnea. So in patient whose mitral orifice are large enough to accommodate normal blood flow with only mild elevations of the LA pressure, marked elevations of this pressure gradient leads to dyspnea and cough. So basically remember, so LA pressure is considered like 25 mmHg. Okay, so significant change in the left atrial pressure, we say it when it is like 25, more than 25 mmHg of pressure in the left atrium. Normal left atrial pressure is actually 2 to 12. The normal left atrial pressure is 2 to 12, but here the pressure, it increases so much up to 25 mmHg. Okay, so in patients whose mitral orifice are large enough to accommodate normal blood flow with only mild elevations of LA pressure, marked elevation of this pressure leads to dyspnea and cough, precipitated by sudden change in the heart rate, volume, status, or cardiac output, as for example, with severe extension, excitement, a fear, anemia, paroxysmal atrial fibrillation, and other tachycardias, pregnancy, and thyroidoxis. So what does this basically mean? So this means that there is dyspnea. There is dyspnea on exertion. Okay, so exertion, it might be secondary to strenuous exercise, it might be secondary to severe anemia. So again, there is this classification for mild, moderate, severe anemia. Mild, moderate, severe anemia, you can remember the multiple of 12. Okay, so I mean the multiple of 3, 9, 12. So 3 to 9, 9 to 12, and 12 to 14. So if this becomes your hemoglobin level, so this is a mild, moderate, severe respectively. Okay, now as mitral stenosis progresses, lesser degrees, as mitral stenosis progresses, lesser degrees of stress precipitate dyspnea. The patients becomes limited and daily activities, and orthopnea and paroxysmal nocturnal dyspnea develops. So what does this mean? So this means as mitral stenosis progresses, lesser degrees of stress precipitate dyspnea. That means, so even though there is less exertion, there is dyspnea. The patient becomes limited in daily activities and orthopnea and paroxysmal nocturnal dyspnea. So there will be PND, there will be PND, and there will be decrease in the daily activities, there will be orthopnea. The development of persistent atrial fibrillation is associated with acceleration of the rate at which symptoms progress. So very, very important. Okay. So whenever we talk about atrial fibrillation, the most important thing that we have to remember is more blood in the left atrium is equivalent to atrial fibrillation. Okay. That means, so there is more blood in the left ventricle, left atrium, that leads to formation of a re-entry circuit, and that leads to formation of atrial fibrillation. Okay. The person can present with hemoptysis. So atrial fibrillation, if the person has atrial fibrillation, so he'll be having increase in the pulse. Okay, increase in the pulse, increase in the, so you might feel like palpitate. Okay, so you might be having palpitations. Okay, hemoptysis due to the venous congestion. Okay, secondary to pulmonary venous hypertension. There will be pulmonary infection, because why the pulmonary infection? Because more amount of blood in the lungs, that means more prone for infection. Okay, so bronchitis, bronchopneumonia, and lobar pneumonia commonly complicated during untreated mitral stenosis, especially during the winter months. Okay, atrial fibrillation, the thrombi may be in the left atrium, particularly within the enlarged atrial appendages. The same thing that I was talking about. So the valvular area, the mitral valvular area has been decreased, so more blood is present in the left atrium, and this atrial blood, more blood in the left atrium, leads to a formation of a re-entry circuit that leads to atrial fibrillation. And when there is more blood, we know from our Worker's triad that there is hypercoagulability, abnormal blood flow, and we have abnormal blood flow, hypercoagulability, and we have hyperviscosity syndrome. So whenever these components combine, leads to a formation of a clot, that is basically a thrombi, and that thrombi can actually dislodge to any other side, leading to formation of an embolus, right? So the pain often resembles anginal pain due to pulmonary hypertension and right ventricular hypertrophy. I already told you about the right-sided heart failure, and that leads to biventricular failure, increasing jugular venous pressure, low extremity edema, and hepatomegaly. Hoarseness of the voice is secondary to, this is known as Ortner's syndrome. Very, very important. Yes, this is known as Ortner's syndrome, often asked in MCQ examination. So Ortner's syndrome means basically there's compression of the recurrent laryngeal nerve. So it's written here, right? So there's recurrent laryngeal nerve compression, and that leads to hoarseness of voice, okay, which is known as Ortner's syndrome. So why there will be features of infective endocarditis? We know that whenever we talk about rheumatic heart disease can in turn lead to infective endocarditis, right? And of course, infective endocarditis means features of infective. What do you expect in the case of infective? So you'll be expecting fever plus new onset of murmur. Okay, new onset of murmur. So if there is a question leading to Carey-Coombs murmur, so Carey-Coombs murmur is secondary to your rheumatic heart disease. Okay. So let's complete it in a nutshell. So the person comes with dyspnea. The dyspneic features becomes more prominent when it's less than 2.5 centimeters square. The normal volume orifice is 4 to 6 centimeters square. Okay, so it's divided into moderate, severe, and very severe. Very severe means less than 1. Severe means it's basically 1. It's 2.5. Okay, so less than 2.5, and now moderate is 2.5. So at a range of 2.5. Okay, so the thing is, okay, less than 1 centimeter is severe, less than 2.5 is moderate. This is your, so this is just very severe, this is your severe, and this is your moderate. Okay. Okay, great. Now general physical examination, very, very important component. So what is mitral phases? Very, very important next question. So mitral phases means when mitral stenosis is severe, the cardiac output is diminished, cutaneous vasoconstriction results in pinkish purple patches on the cheeks. Okay, the atrial pulses are reduced in volume due to decreased stroke volume. So what does this mean? When mitral stenosis is severe, and the cardiac output is diminished, cutaneous vasoconstriction results in pinkish purple patches on the cheek. So if you look into the cheek area, so this is your person, right? So if you look into the cheek area, pinkish purple discoloration secondary to cutaneous vasoconstriction, secondary to cutaneous vasoconstriction. Okay, so the cutaneous vasoconstriction is so much that it leads to pinkish purple discoloration patches on the cheeks. Okay, the atrial pulses are reduced in volume due to the decrease in the stroke volume, right? And remember that there's the JVP, there's a prominent A waves. There's a prominent A waves reflecting elevated left atrial pressure, of course. Okay, so whenever we talk about JVP, there's an increase in the A waves. Okay, secondary to increase in the right atrial pressure. Okay, the A wave is absent in patients with atrial fibrillation and only prominent V wave is seen. Okay, so not much to explain. Just remember that mitral phasis is seen secondary to cutaneous vasoconstriction, which results in pinkish purple patches on the cheeks. And in JVP, you can see that there is a prominent A waves. Okay, prominent A waves. Now, palpation and percussion of the chest wall reveals an apical impulse that is generally normal. Okay, so apical impulse is normally felt. Okay, okay. The right ventricular heave, parasternal lift, and palpable P2. Long examination demonstrates crackles, bilateral basal crackles secondary to pulmonary edema. Advanced disease may be associated with the signs of right-sided heart failure, right? Now, right ventricular heave, parasternal lift, okay? So you have to palpate it with the ulnar border, okay, at the area of your sternum. When you palpate it, you will feel a parasternal lift. Parasternal lift, okay? It's a heave, okay? Right ventricular heave, okay? And next is palpation and percussion on the chest. So if you just feel it, you can feel the apical impulse, okay? Now, S1 is attenuated. S1 is when you just go for a cardiac auscultation. When you go for a cardiac auscultation, the S1 becomes attenuated. The S1 is attenuated and it's slightly delayed. Just remember S1 is attenuated, right? So there is an opening snap. So you can just make a diagram over here. So S1 is very much attenuated. There is a S2. There's a E2 like this. First, always there is E2 always comes before P2. Okay. Then what is there is a mid diastolic murmur, and this continues. Okay, continues. So opening snap will be heard. The mitral valve must open, right? So opening snap is heard. Okay, so opening snap of the mitral valve is most readily audible in the expiration or just medial to the cardiac apex. This sound generally follows the sound of the aortic valve closure A2. The time interval between A2 and opening snap varies inversely with the severity of MS. The opening snap is followed by low-pitched rumbling. Low-pitched opening snap is followed by followed by a low-pitched rumbling diastolic murmur, heard best at the apex, with the patient in left lateral recumbent position with pre-systolic attenuation at the height of expiration. Add it over here, at the height of expiration. So this word, it's so important. Okay, the opening snap is followed by a low-pitched rumbling diastolic murmur, heard best at the apex, with the patient at the left lateral recumbent position with pre-systolic attenuation at the height of expiration. Okay, so it's attenuated by mild exercise, of course, a few rapid sit-ups carried out just before auscultation. In general, the duration of murmur correlates with the severity of stenosis. Okay, hepatomegaly, ankle edema, ascites, and pleural effusion, particularly in the right pleural cavity, may be associated with mitral stenosis with right-sided heart failure. And if there is associated thyroid dysfunction, okay, so with severe pulmonary hypertension, a pansystolic murmur produced by functional tricuspid regurgitation may be audible along with the left sternal border. The Graham-Steele murmur of pulmonary regurgitation, a high-pitched diastolic decrescendo blowing murmur along the left sternal border. So this is actually an additional information. The must to know thing is over here. This is must to know things. Okay, so you can see here curly B lines secondary to, see curly B lines, it's written here, right? So curly B lines secondary to pulmonary edema. Okay, So normal to increase in the cardiac shadow, double density, straightening of the left heart of the of the border, and elevation of the left main bronchus, and posterior displacement of the esophagus by the yes. So there will be posterior displacement of the esophagus by the enlarged left atrium. That is very, very important, right? And you can see that there is an increase in the cardiac shadow. Okay. Uh, Mitral valve calcification can be seen. Coily B lines can be seen. And you can see prominent pulmonary vessels. Okay. Prominent pulmonary vessels are seen. Okay. Now echocardiography. So we ended here. We'll add in the next slide.